Good afternoon. Thank you for joining the National Health Council's webinar on the Inflation Reduction Act, Overview, Impacts, and Next Steps. I'm Randy Ruda, Chief Executive Officer at the National Health Council, and I'll start by welcoming our NHC members who play such a vital role in driving improvements and change on behalf of patients throughout the health ecosystem. And welcome also to those of you at organizations that are not yet National Health Council members. Gatherings like this one are a great example of the power and value of the National Health Council community. So earlier this week, President Biden signed into law the Inflation Reduction Act, which includes significant provisions related to Medicare Part D, the Affordable Care Act, and pharmaceutical drug reimbursement. While the legislation outlines key features in each of these areas, we know that much of the impact will depend on how the administration implements this new law and how various stakeholders will respond to this legislation and its regulations. Additionally, the patient community has hoped to see additional investments in the healthcare system, such as addressing the Medicaid coverage gap. So today we're going to offer an overview of key features of the legislation, describe potential areas to be addressed in implementation and future legislation, and discuss what the role of the patient community can have as we move forward. And we'll be sure to leave time to answer any questions that you may have at this point. Please feel free to utilize the Q&A function throughout the webinar, and we'll get to as many questions as we can. Now, for those of you that aren't familiar with our organization, let me provide just a brief introduction to the National Health Council. The National Health Council was created for and by patient organizations more than 100 years ago. The National Health Council brings diverse organizations together to forge consensus and drive patient-centered health policy. We promote increased access to affordable, high-value, equitable, sustainable healthcare. We're made up of more than 145 national health-related organizations and businesses, and at its core, the National Health Council includes the nation's leading patient organizations. Other members of the National Health Council include health-related associations, nonprofit organizations, including the provider, research, family caregiver, communities, and businesses representing biopharmaceutical, device, diagnostic, generic, and payer organizations. If you're not a National Health Council member, we would welcome the opportunity to talk to you about the benefits of membership. So feel free to add your contact information in the chat or reach out to us with any questions that you may have. But I'm very pleased today that I'm joined by two very knowledgeable, respected colleagues and friends. Eric Gasho, Senior Vice President of Policy and Governmental Affairs for the National Health Council, and our colleague Matt Kazin, Managing Director at Avalere Health. I am delighted that these individuals will enlighten us as to the IRA and what our next steps might be. So now I'll turn things over to Eric to kick off the program. Eric?
Thank you, Randy. And I would also like to thank everyone for joining us today on a Friday in what's turned out to be an unusually busy August. I'll start by saying that we know that many of you have strong feelings about the Inflation Reduction Act. Many of our members supported it, many opposed, and many, if not most of our members are somewhere in between. The NHC was officially supportive of some of the provisions, but we did express concern with others. A link to our letter and our statement that we sent will be posted in the chat, and I would refer you to that. However, today's session is really intended to be informational in nature and forward-looking. Despite the amount of time and effort many of us have poured into analyzing and responding to the bill, we know there are still a million questions that folks have. What exactly is in it? When do the changes take effect? What were some of the last minute changes that were made to it? How will CMS operationalize many of the new requirements? And importantly, what opportunities does the patient community have to participate in any future decision making? Some of these questions we hope to answer today. As Randy mentioned, others will really depend on how the law is implemented and how various industries respond. We want to use today's session to tee up some of the major provisions and some of those key future determining factors. And your questions may also help us think about what are some of those potential challenges that will need to be addressed in implementation. To help us think through all of this, I'm pleased to introduce today's speaker, Matt Kazin. As Randy mentioned, is the Managing Director at Avalere Health. Matt provides strategic advice to health plan and life sciences clients. I'll also add patient organizations such as the National Health Council, navigating the complex legislative and regulatory policy environment with a particular expertise in Medicare Part D and Medicare Advantage. Prior to joining Avalere, Matt spent over a decade on the Senate Finance Committee staff under Senators Baucus and Wyden. As senior health policy advisor, Matt was the primary advisor on policy issues, including Medicare Advantage, Medicare Part D, and all drug reimbursement under Medicare, chronic disease, dual eligibles, post-acute care, the Medicare Shared Savings Program, and Medicare Medicaid program integrity. So as you can tell, very expert on many of the things that we'll be talking about today. When he was with the committee, he worked on a variety of major legislative accomplishments, including the Affordable Care Act, the Bipartisan Budget Act of 2018, MACRA, the CHIP Reauthorization Act, and the American Recovery and Reinvestment Act. Matt holds an undergraduate degree from the University of Denver and a Master of Public Policy from George Washington University. Before he does speak, I have a couple quick housekeeping items. The session is being recorded and will be distributed to attendees after the meeting. Everyone except the speakers will be on mute. As Randy mentioned, if you have any questions, please use the Q&A function. If you'd like to make a comment, please use the chat function. If you have any questions that are technical in nature, please send an email to nhcmeetings@nhcouncil.org. And finally, please remember to complete the evaluation form that you'll be linked directly to when you log out. With all of that out of the way, I'm going to hand it over to Matt.
Very good. Thank you, Eric. Thank you, Randy, for the invitation to speak today. Good afternoon, everyone. Really pleased to be here and talking about the impact of the Inflation Reduction Act, particularly on patients. As Eric and Randy teed up, I think my purpose today will be to kind of highlight the major provisions in the IRA, maybe focus on some of those changes that occurred in the final version that were not present in the previous versions, and then call out a couple of key provisions that have a disproportionate impact on patients or have an opportunity for patients to weigh in on, as Eric and Randy both talked about, what will be a large amount of kind of regulatory action implementing this law. So let's dive in here. As I said, we'll go one more, sorry about that. We'll focus most of our time on the three main provisions in the law, which are Medicare Negotiation, Part B and Part D inflation-based rebates, and the redesign of the Part D benefit structure. That is not to say that there are other meaningful provisions in the law, including changes to the ACA, changes to insulin and cost sharing, but we will focus on these three main provisions. Just a level set for folks, at a very high level, Medicare negotiation begins in 2026 for Part D drugs and 2028 for Part B as in boy drugs. But as we'll get into, the process related to negotiation will kick off much sooner than that. The Secretary of HHS will identify drugs that are eligible to be selected for negotiation. This list of eligible drugs are essentially drugs that have been on the market for a minimum amount of time, that do not have generic or biosimilar competition, and where Medicare spends a substantial amount of money on those particular drugs. There's a host of kind of exceptions and carve-outs and special rules as it relates to that we can get into if folks are interested, but that is essentially the eligible drugs. The Secretary will select drugs from that list, and the number of drugs that will be selected will be dependent on the year. We'll get into that a little bit. And the negotiation will result in a maximum fair price, which will be the price that will be used for Medicare reimbursement and cost sharing, both in Part B and Part D. So we will get into a little bit more details here in a second on that one. Inflation rebates, this will affect both Part B and Part D products, where essentially Congress has established a somewhat complicated math formula where essentially a benchmark price and a benchmark rate of inflation will be used, and that will be compared against actual prices for Part B and Part D drugs, and manufacturers will be required to pay a rebate if their prices exceed that benchmark price. And then finally, Part D benefit redesign, which will make wholesale changes to the Part D benefit starting in 2025, which will include a $2,000 out-of-pocket cap for beneficiaries, a restructure of the mandatory discounts that manufacturers must pay, and shift in a variety of different ways financial liability from the government onto Part D plans. So those will be the three main provisions that we'll focus on today. Let's start with a little bit of a deeper dive into Medicare negotiation. So if we advance one more slide. Perfect. So as I said, the legislation is pretty specific in terms of the drugs that are eligible to be negotiated. Starting for plan year 2026, the Secretary will select 10 drugs under the Part D program that will be subject to the negotiation policy. A couple questions and clarifications that we've gotten related to this provision have been, in subsequent years, are the number of drugs additive or is it replacement? And the legislation makes it pretty clear that the number of drugs that are selected is additive, so that in 2026, 10 drugs will be selected. In 2027 and 2028, 15 additional drugs in each of those years will be selected. And then starting in 2029 and thereafter, 20 additional drugs will be selected. So essentially in the first 5 years of this policy, a total of 80 drugs will be selected for negotiation. Again, once you are selected, you will remain selected until there is a generic or biosimilar competitor on the market. And then you will be, in my words, kind of unselected, and another drug will be replaced by the Secretary. As part of the negotiations, the Secretary and manufacturers will eventually reach what's known as a maximum fair price. Their legislation sets a ceiling price for this maximum fair price, which is essentially a % of the drug's non-federal AMP, which is essentially the drug's price in non-federal programs. The longer a drug has been on the market, the steeper the discount will be off that non-federal AMP, so ranging somewhere between 40 and 75%. This maximum fair price that will be set will be used both for cost sharing, both for Part B and Part D, as well as reimbursement for that drug, either for Part D plans or for Part B providers. A couple of, I think, key changes that will impact the effect of this policy that were made in the final version as compared to recent versions. Obviously, the shift in implementation date going from 26 and 28 for Part D and for Part B respectively is a change, but a lot of major changes around which drugs will be selected. In previous versions of the bill, all insulin products were required to be selected under the negotiation policy. That is not a requirement anymore. Insulin products could be selected if they meet all the criteria that are outlined in the bill, but there is no automatic inclusion of insulin products. And then a final change relates to biologics and biosimilars. If a biologic is set to be selected by the Secretary, but there is a chance in the Secretary's eyes that a biosimilar is highly likely to come to market in the near term, the Secretary can delay the selection of that biologic drug for up to 2 years. So that is certainly important policy in some certain narrow circumstances. Those are really the key big changes that occurred, I think, last minute as it relates to negotiation. So let's shift to the next policy on the next slide and go through a similar exercise. Part D redesign, as I said, really is wholesale change to the Part D benefit. And we've kind of graphically illustrated what the Part D benefit will look like once these changes take effect in 2025. That's a key difference from previous versions where these policies took effect in 2024. Congress shifted that implementation date to 2025. So as I said, thinking about this graphic, thinking about going it from the top to bottom as a beneficiary spends money over the course of a plan year, the coverage gap is no longer in existence, and we essentially have an initial coverage period and a catastrophic phase, which occurs after a beneficiary reaches that $2,000 out-of-pocket limit. As you can see, manufacturers will pay a discount throughout the benefit phase, a 10% discount below that out-of-pocket cap and 20% above that out-of-pocket cap. Beneficiaries will face no liability once they reach that $2,000. And plans in a number of ways will see greater financial liability for the Part D program. One other big change compared to current law is those manufacturer discounts will apply to LIS or low-income beneficiaries, whereas today the coverage gap discount does not apply to those folks. One very important provision as it relates to patient impact is around out-of-pocket smoothing, which also takes effect in 2025. This will allow any Part D enrollee to essentially smooth or spread out any out-of-pocket costs that they have for the remainder of the calendar year. So for instance, if a beneficiary goes in, has a script that needs to be filled in February that reaches that $2,000 out-of-pocket limit or a lower limit, for example, rather than pay that amount all at once at the pharmacy counter, they can elect to spread that cost over the remaining months of the year and pay a much smaller monthly amount. The couple of changes that occurred in this provision as opposed to, or in the final version as opposed to previous versions, I already touched on one related to the implementation of redesign in 2025. They did make one change as it relates to 2024. They're not redesigning the whole benefit structure, but Congress is eliminating out-of-pocket costs for beneficiaries who reach the catastrophic phase in 2024. So essentially an out-of-pocket cap at a slightly different dollar amount than the $2,000, but good news for patients that do reach catastrophic. They will no longer face that 5% coinsurance liability. The other change, maybe going slightly in a different direction, is in previous versions, in that initial coverage period, beneficiary cost sharing was going to be set at 23%. Congress has reverted that back to the 25% coinsurance that beneficiaries pay today in the initial coverage phase. And so the final major policy, if we go to the next slide, relates to inflation-based rebates. Again, this is a kind of complicated math formula that Congress has set up to calculate the rebates that manufacturers will pay, but essentially at a high level for Part D and for Part B products, if a drug's AMP for Part D or ASP for Part B exceed this inflation-based benchmark price, those manufacturers will pay a rebate back to the Medicare program. A big change that was made in the final version of the IRA as it compared to previous versions was the calculation of how much rebates those manufacturers would pay. In previous versions, the bills said that the rebate would be based on both Medicare volume and commercial volume of those products. The final version removes the commercial volume aspect of this calculation, meaning that manufacturers will pay a much smaller rebate if they have a lot of commercial volume. Another kind of more nuanced change is that the final version excludes any units for which there's a 340B discount on those units from the calculation of the rebates that manufacturers have to pay. So not a whole lot of changes, a couple date changes in terms of how the benchmark is set and what the comparison will be to actual price, but really significant changes in terms of the kind of volume aspects, how many units the inflation rebate will be subject to. So important call out there that I wanted to make sure folks were aware of. So those are the big three policies that I wanted to go to in some level of depth. As Eric said, happy to try to answer any questions. Before I turn it back over to Eric, I did want to highlight throughout the bill, there are a lot of key areas on the next slide, ways in which patients are going to be directly impacted disproportionately, and or opportunities for patients to weigh in as CMS and HHS think about implementing these particular provisions. So starting with the Medicare negotiation policy, obviously which drugs get selected and which do not will have a direct impact on patients in terms of cost sharing that they will pay, as well as the plan behavior and provider behavior related to those drugs when there is a reimbursement change. That will certainly be felt on the maximum fair price. One area of potential engagement that I wanted to call out is related to the negotiation process itself. 2026 does sound pretty far away, but Congress started for that first year, 2026, the negotiation process much sooner. And in fact, in about 12 and a half months, on October 1, 2023, the Secretary is going to name those 10 products that will be subject to negotiation in 2026, and that negotiation process will start that day. Congress provided some outline into how that negotiation process is going to work. They provided some parameters, some criteria, but a whole lot of details about how that negotiation process is going to play out, and what, if any, role there will be for patients and patient organizations to determine the outcome of the negotiations will really be up to the regulatory activity of CMS. That regulatory authority could be done through kind of more unconventional means. It is Congress gave the Secretary the ability to not do this through kind of your more typical proposed rule, comment period, final rule, but more through program instruction and guidance. So we would anticipate, given the tight timeline of this, for HHS to take advantage of that authority and start to use more kind of regulatory, sub-regulatory type guidance documents to outline that. But certainly having the patient voice within that negotiation policy will certainly be important for folks. And so that is one key area that I think folks do want to think about as this process rolls out over the next couple of months. On Part D redesign, already touched on some of the direct patient impacts, obviously the $2,000 out-of-pocket cap, the 2024 change for catastrophic, and the smoothing policy, all big wins for patients and beneficiaries. Like negotiation, there is some ambiguity and potential rulemaking or regulatory activity related to smoothing. Certain circumstances that I think are just going to need to be spelled out, right? What happens if a beneficiary changes plans mid-year? Does their smoothing kind of go with them, so to speak? Is there any opportunity for CMS to deal with circumstances where, say, a beneficiary, their first large costs that are incurred happen really late in the year, and there's not a whole lot of months for them to smooth those costs over time? Is there any flexibility that CMS sees to try to deal with that circumstance rather than smoothing that over a 1 to 2 month period, which isn't going to have as much of an effect as there would for a beneficiary who's smoothing, say, starting in February, March of a plan year. On inflation rebates, maybe a little bit less discretion than those other policies, but certainly there is a patient impact, especially on the Part B side, as it relates to cost sharing. Their cost sharing will be based on that inflation-based benchmark. And so making sure beneficiaries and providers are aware of that provision will certainly be important. And then on some of these other provisions related to Part D, huge patient impact. For instance, the LIS expansion, essentially the bill gets rid of, for all intents and purposes, the partial LIS category, and essentially expands full LIS eligibility for all beneficiaries up to 150% of the poverty. This is a relatively small kind of sliver of the Part D program, about 300, 400,000 beneficiaries. But for those beneficiaries, the difference in cost sharing protection is very significant. We know that LIS and other kind of dually eligible Medicare savings programs, these often have challenges with folks who are eligible but not enrolled in this program, and we would anticipate this be no different. So getting education and outreach out to this particular patient population about this change will be extremely important. Another big change that happens relatively quickly is on the insulin cap. This goes into effect in plan year 2023. There's going to be a lot of complicated mechanics about making sure that this works smoothly, given that plans have already submitted their bids and their benefit design for 2023. The legislation does contemplate some kind of payments made directly by plans to patients in the beginning of 2023. So that has a lot of, I think, moving pieces, and I think patient orgs are going to need to really be focused on the implementation there to make sure that it's smooth and that that the policy itself meets the intention of this out-of-pocket cap. And then finally, Congress has put in place a premium stabilization program to cap the base beneficiary premium for a limited period of time so that those premiums don't increase year over year more than 6%. Not a whole lot of active engagement for patient groups to do on implementation of that, but certainly something to be aware of as all these changes roll out. Lots of moving pieces about plan bids, plan premiums. Know that there is a little bit of a protection on the premiums there in those years 2024 to 2029. This slide certainly is not an exhaustive list of all the patient impacts or areas of engagement, but some of the things that we wanted to highlight in terms of key areas or immediate areas that folks like NHC and some of the organizations on the line would want to engage in. So with that, I will pass it back over to Eric for his thoughts and comments. And as I said, happy to try to answer any questions that folks may have.
Great, thank you so much, Matt. And folks want to start populating the questions and the Q&A function, please feel free to do that now. But while those are coming in, do want to just add a couple sort of additional points and a little extra flavor and context. I think, to Matt's point, that is not an exhaustive list of a lot of the patient impacts and opportunities to engage. So, as we move forward with anything of this size and scope and impact, I think we'll continue to identify those. And certainly as those start to kind of jump out at you in conversations you're having or things like that, please feel free to shoot me a note. We'll continue to do that work. But I think a couple that have really sort of risen to the top for us, I think are really on that sort of role for or lack thereof in the legislation, at least for the patient advocacy community to really provide perspective in the negotiation process, I think is very much within the NHC's bread and butter. We've done a lot of work as it relates to providing the patient perspective in medical product development and coverage and value assessment. I think it's a very natural fit for sort of extension of the work that we have been doing to really apply it in this place as well. But there needs to be a process in place for that opportunity to exist. And so step one is to really advocate for that. And then step two is to help operationalize it. The other I really want to highlight is on particularly the patient smoothing piece. I know we'll be working with groups like MapRx and other organizations that have been great champions of smoothing to really make sure that that works well. Certainly, while this was one of the better, in my opinion, versions of smoothing that we'd seen across all the various Part D redesign proposals, there's still a little bit of work that needs to be done, particularly as it relates to how people know that they're eligible for this, how we're really making sure that as many people take advantage of this that will benefit from it as possible. I'm really thinking through sort of things like grace periods and missed payments, et cetera. So really making sure that that's going to be as strong as possible, both for the Medicare Part D beneficiaries, as well as really thinking about what are some of the lessons learned if we get that right that can be applied in other health insurance markets as well. We've been for a long time pushing for smoothing in the ACA marketplaces. I still will never forget when we commented on the first notice of benefit and payment parameters under the Trump administration asking for that. And the response back was that, well, we don't know any health insurance market where this currently exists. Well, pretty soon we will have that within the Part D program. And so thinking about how we can take the lessons learned there and think about how that can be applied elsewhere, I think will be really important. And similarly, I think with the insulin cap, I think Matt made a good point that there's a lot of work that needs to be done to get that right. But what can we learn from copay caps for insulin in the Medicare market? Is that possible that there'll be legislative efforts to expand that beyond Medicare into the commercial market? Can we expand it to other types of drugs in addition to insulin? I think there's a good opportunity from a sort of best practice that may be developed there. And then last but not least, really thinking about sort of where do we go forward on the legislative side. So obviously a lot of work to be done on implementation, and we will continue to lead on those efforts. But there are a lot of things that the patient community had pushed for that were maybe included in the Build Back Better Act or other packages of this size and scope, such as addressing the Medicaid coverage gap, home and community-based services. There are a number of other things that we still want to very strongly push for. in addition to having to push for the ACA tax credits 3 years from now. So we know that's going to be up for debate sooner than we know it. So really thinking to make sure that we continue to push for some of these things that could have transformative impact, and certainly things that will need to be reauthorized. So that's certainly as much effort as we've been putting into this. Know that the work is only beginning. So with that in mind, do want to move on to questions and answers. So we do have one question so far. Again, please feel free to enter any that you may have. First one is from Ellie Dehoney. She wants to know, do we know whether volume or price tends to determine the top spend of Part B drugs, and whether the drugs are disproportionately used to treat a particular type of illness? For example, for cancer, arthritis, Crohn's, et cetera. So I'm curious if we have a sense of sort of what's driving that, and probably meaning, how is that going to impact which ones will be included on the list for negotiation or not?
Yeah, it's a fantastic question. I would say a couple things. Certainly differences in factors as you think about B versus D. I think D drugs that are likely to be selected, definitely driven by utilization. I think B certainly driven both by price and utilization a little bit to more extent. I think the question certainly teed up the type of diseases and TAs that are likely to be implicated by B. Certainly biologics will be some of the products most likely to be selected in the Part B side. We'll caveat though that this is all kind of interrelated, both B and D, especially obviously once we get to 2028. So to a lot of different factors that go into effect including generic and biosimilar competition coming onto the market. As that happens, some products get deselected, other products come on. So there's a definite interactive effect. Our kind of team of kind of pharmacy, FDA, and LOE experts have come up with our projections of which drugs get hit and which years that they do get hit. I don't have that right in front of me, so I couldn't give you the TA specifically. But certainly oncology, certainly arthritis would be the ones that I would expect in those first years in 2028. We can also circulate, I think we put up an insight related to the total amount of spend that will be included in the first several years of negotiation based on how the parameters of the law set. We can circulate that to Eric, who can circulate to folks on the call.
Great, thanks, Matt. Others have other questions, please enter them in. But I guess I'll kind of ask another one. I know you sort of touched on this a little bit, just thinking through timing. I know a lot of this is very speculative, but in terms of some of the kind of fast approaching deadlines that you mentioned, anything that would probably be front and center of things that we might expect to see first, where there is going to be particular attention need to be paid by the patient community?
Yeah, I would say the rules of the road related to the negotiation process. If this is going to start in earnest, really, in 13 months from now, that's one of the areas of the law that's a little bit more vague and delegates a lot of authority and decision making to the secretary, and certainly is going to be a ton of focus and scrutiny on. And so defining those rules of the road well in advance of when that starts, I think will be probably very important for HHS and CMS. The insulin cap for 2023 is another area that I would certainly focus on. Usually changes to Part D occur certainly well in advance of when bids and benefit designs are set, but certainly before the rate notice and rule related to that plan year are set. In this instance, we not only have had a rate notice for 2023 finalized, we've had plans submit their bids and get their bids presumably approved by CMS that did not incorporate changes in out-of-pocket costs for a product like insulin, where there is a lot of utilization. So how the mechanics of that are going to work and how CMS is going to deal with the various stakeholders to ensure that those out-of-pocket, that cap occurs, in 2023, CMS is going to have to hustle and put out, I think, guidance both to plans as well as to beneficiaries and pharmacies relatively soon. Things like benefit design and even the change to 2024, that I think can wait a little bit towards the normal rulemaking cycle that will occur. So I think most of the action in the early days will be on negotiation and that insulin cap.
Great, thanks, Matt. And I know that your expertise is more in the Medicare side, so I'm going to frame this question more by asking you to put on your former congressional staffer hat and kind of thinking more on the politics and sort of process side, but thinking about some of those things that were kind of left on the table, like addressing the Medicaid coverage gap. Any advice for the patient community? Obviously, this was probably one of the biggest bites at the apple, using the budget for reconciliation and kind of thinking through potentially heading into a split Congress, if not a Republican-controlled Congress. Any advice for the patient community in terms of how to really make sure that some of these things that were left on the cutting room floor kind of remain front and center with our friends and champions on the Hill?
Yeah, absolutely. I would think about two things that come to mind quickly, specifically related to the Medicaid coverage gap. Obviously, in a reconciliation instruction or any of these healthcare bills that Congress is cobbling together or has put together in past, a huge factor is related to the CBO score. And are there enough politically viable pay-fors to offset those that new spending? And in this case, we had a unique circumstance where in order to get 50 votes in the Senate, there had to be a minimum level of deficit reduction. So the actual amount of spending had to be well south of the actual offsets that could be agreed upon. And that presents a challenge for things that cost a lot of money. And we know changes to coverage, generally speaking, cost a lot of money. So thinking about policies that can be narrowly tailored to try to bring down that CBO score, and or evidence or data that can be provided to CBO to get them to change their thinking to bring down that score is always, I think, important first steps. I think on the substance in particular for this provision, linking the Medicaid coverage gap to the PHE and what is going to happen after the PHE expires will be incredibly important. And so you always kind of want to keep policy proposals in the front of minds of policymakers in Congress. And there is an obvious connection between the expiration of the PHE, the redeterminations, and the Medicaid coverage gap. So I would, if I were a patient organization or an advocate in this space, certainly be thinking about ways in which to continue to connect those dots there and keep it on front minds of policymakers and figuring out, and this is easier said than done, is there a way in which the Medicaid coverage gap becomes a bipartisan issue? Given, Eric, I think what you said around the midterms elections and the likelihood of a potential split Congress, things that are going to be done are going to either have to be bipartisan or something that the administration does unilaterally. Is there a way to handle this issue in either of those scenarios? Very tough to say, but that's the kind of type of thinking that one would need to go down to try to see if they can advance this really tricky issue.
Great, thanks, Matt. And I will say both the giving CBO data to change their mind and thinking about the end of the PHE also is related to another priority for a lot of folks in terms of extending the telehealth waivers as well. So
that's a very good point. Yep.
But yeah, great advice, just generally speaking, in addition to being specific to the Medicaid piece. I am not seeing any additional questions. Maybe I'll give it another 15, 20 seconds, make sure people can get their questions in. All right, I am going to take that to mean that your presentation answered all of the questions that folks had coming into this. So certainly thank you for that. But I sort of jokingly say that I know there'll be more that'll come up as we move along. And so I will just close this out by, again, thanking everyone for joining us. And you see my email address there. It's egasho@nhcouncil.org. please feel free to reach out if anybody has any questions about this or anything else that we're working on. Again, I'll reiterate what Randy mentioned. For those of you that may not be NHC members, always feel free to reach out and look to bring you into the fold as well. And these are the types of opportunities that we provide for our members, like bringing in experts such as Matt to really explain to folks what all is going on. I do have one other question that came through. Yes, the recording will be shared afterwards. So I know that probably a lot of people were not able to join us on a Friday afternoon, but thank you to those who have. We'll make sure we send you the recording in addition to folks who maybe weren't able to join. So again, Matt, thank you so much. Randy, I see you're coming on the camera. If you want to add any additional comments as we close out, but I will just thank everyone for joining.
I would do the same, Eric. Thank you so much, Matt, for that just great analysis. We really appreciate you, particularly walking us through, where we find ourselves currently and how we go forward. As Eric suggested, I feel a real sense of urgency to be proactive in positioning the National Health Council, its members, the patient community at the table, with the regulators and others that are charged with implementing these various provisions. And so stay tuned. We'll be keeping you abreast of our efforts in that regard, as well as collaborating with other coalitions and voices that are so strong in this space like MapRx. So thank you, Matt. Thank you, Eric. And thank you all for being on this call today. Our work in many ways absolutely continues. Maybe it just begins a new phase. So thank you.